All right. Hi, everybody. My name is Beth Holmes, and I'm here today with Mehul Agarwal of Health Compiler and Dr. Ken Richter of Genovo Health. And today we're going to talk about what Health Compiler is doing with the direct primary care world. So thanks to all of you for joining. And if you tried to join us last week and weren't able to, we apologize. There was a system-wide outage with our streaming service. So thanks for persisting and joining us today. I'll turn the mic over to Mehul and Dr. Richter to give you a little bit more information about their backgrounds. Mehul, do you want to start?
Absolutely. Thanks for the opportunity. And absolutely. So, my background has been in healthcare technology for a long time, played a lot with health interoperability and integration, enabling practices, hospitals, healthcare software companies to exchange data. We then started Health Compiler with the thesis of where we can make the most impact in the healthcare. And we then realized that the great care is already happening. Is just the whole movement need to be known better. Plus, the data sits at the epicenter, so that everyone who's part of the movement knows the impact and the value it's getting delivered. We're just unveiling the value of direct care, direct primary care specifically, and enhancing it for everyone, like employers and partners, to know about the great care that's being delivered.
Awesome. Dr. Richter, tell us a little bit more about yourself and your practice.
Yeah, hi. I'm Dr. Ken Richter, and I've been in private practice, family medicine, primary care for 37 years. And so I was able to see when fee for service was a great model where we had no problems and you plopped your flag in the ground and started your practice and saw people in the hospital, and the full-fledged kind of Norman Rockwell picture of what the doctor was is what I was. And then probably about 12 or 13 years ago, I could really sense that things were going south as far as the fee for service world. We were called on to do so many different things, so many different codings, so much less time with patients just to keep our doors open. And I discovered direct primary care at that point. It was very young at that point that I discovered it, and visited a practice to see how does this work? How could I do it? And in 2014, I converted my practice from fee for service to direct primary care. So we're 11 years into doing DPC at this point, and truly the best professional, medical, personal, business decision I've ever made. Will never go back. Just has been great for everything going. We formed Genovo Health, other than my practice, to be able to help other practices out, to be able to get patients, kind of intermediary with businesses, to be able to show the benefit of doing direct primary care with self-funded plans and different types of insurance markets, so that we can show the value of DPC, and be the in-between between the business and the practitioner.
That's great. So for those of you on today, we're going to talk a little bit more about, what Health Compiler's offerings are, how Genovo is using them, kind of how they're working in the real world, and talk a little bit about how Hint Connect is also partnering with Health Compiler. So we welcome your questions throughout the webinar. We can see them, we'll pull them up and try to answer them as you send them in, but we should have some time at the end of the webinar as well to continue on and stay for questions. So, I think, Mehul, can you kind of get started and tell us a little bit more about what you mean by more people need to know about DPC or see the value of it? When you were starting Health Compiler, what was the what were you seeing there, and why did you choose kind of the data aspect of direct care as the entry point that you wanted to solve?
You bet, absolutely. So, Dr. Richter was one of our first customers, and I vaguely remember, when he received an email from one of the employers that he was working with on, asking for the reports, and the reports are actually, scattered around various systems, and they don't necessarily tell the story, which is easily digestible, especially when the folks, like the whole benefits team or the CFOs, are trying to kind of understand what does it make sense for them to self-fund it or to work with a DPC practice. So with that thesis, and some ideas, we actually went back to the drawing board and started to understand what is the value story that would really make a mark. And that's when we actually started Health Compiler's data analytics journey beyond the health integrations that we were doing all this while. So basically, if I talk about communication tool or hints billing system or another EHR like Elation or Hint Clinical for that matter, a lot of clinical uh, you know communication data and very important patient data resides there. Um, and we tell a value story like this much cost has been saved while you're paying a monthly fee. Look at the engagement and utilization. uh, Look at the population of the chronic diseases, and we segment that. So the employer understands what they're dealing with, what could come, and also they could look at that they are getting value out of the DPC program if they are paying for it.
Yeah, at Hint, we look at employer trends in DPC. We'll have a new report coming out within the next month or 2 months. And what we see is that about 45% of DPCs are, kind of phone ringing, maybe. Um, about 45% of DPCs using Hint are working with employers, and about 55% of all DPC memberships are employer sponsored. So there's been tremendous growth in DPCs working with employers, either on a one-to-one basis, with the small local employers, or on a many-to-many basis, like through Genovo or Hint Connect. But they're really, from what I've seen, aren't solutions in the market to help show the value. I think DPC has been built with the value being experienced by the patient in retail. And so as more employer-sponsored DPC comes up, this is really filling a need. Dr. Richter, what was your experience, having worked with employers for the past several years of all sizes in terms of what they were asking from you, and what you were doing before working with Health Compiler?
Sure. No, that's a great question. So, it's when you start out with a DPC practice, you want to kind of hit a grand slam and go out to a business that has 600 employees, and then, you're the only doctor and you go like, gosh, I made it. But that's also a time bomb, because if they pull out, you're kind of dead in the water. So the recommendation for DPC is you want to have multiple businesses, multiple business connections, multiple private connections, multiple ways of having your patients coming in. But that also determines that as a retail patient that I would have for direct primary care, their concerns of that patient is, am I getting the care that I want? And the patient is very able to say, am I getting my money's worth? Just like we would of a Netflix subscription, for instance. If we look down a Netflix subscription and after 6 months we're not watching it, we're going like, what use is it? And we're going to drop it. So with a DPC subscription membership, they're saying, am I getting my return on my investment? An employer looks at things differently, and that's what I learned. As Mahu mentioned, a CFO looks at something differently than HR. HR looks at something different than the CEO, and you have to answer all those questions. Most of the CEOs want their employees to be happy. They want to be financially responsible, but they're really concerned that their patients, their employees, are getting the healthcare they need. The CFO is concerned about dollars and the return on investment. And they want to know, if I'm putting in so much per month, what am I getting back out in investment? What's the bottom line for that? As a direct primary care doctor, I don't have those tools. I can't pull this out from that. And as a direct primary care doctor, also, I'm using multiple avenues for communication. I'm using my chart, I'm using my phone, I'm using a Spruce connection tool with virtual visits, with text messaging. I'm doing out of office, in office, I'm doing out of hours, in hours. And all that becomes very important data, because the key to DPC, I believe, is access. You want to be able to get a hold of your doctor when you want to get a hold of your doctor. And that's what's missing in fee for service. A CFO wants to see that if I get access to that doctor at 7 o'clock in the evening and he's able to respond to that patient and keep them out of urgent care or an ER, I've just saved this amount of money. There's no tool to be able to measure that except anecdotally. And you might say, hey, I think this is a good thing and I feel good about it. And the CFO goes, I need to see the dollars. I need to see the numbers. I just can't feel good about what's going on. So that's what prompted me to contact Mo, because more of the employers were saying we really would like to see some numbers, just really crunched numbers. And with Mahou's team, with Health Compiler, they're able to go into all of my forms of communication, whether it's Spruce or Elation for my medical software, and pull this information out and get a real-time value of, gee, how many patients am I seeing after hours as far as text? How many people are using text messaging? How many people are using our portal? How many people are we avoiding for urgent care and for ER visits? How many people are we able to do prescriptions refills without an office visit? That's a value in itself. And then you come out with concrete numbers for the employer. And so far, the feedback's been really good with that. And it only encourages more employments. It only encourages more employers. So not only are you doing that to charge up the employer that's already invested with you, but it is an unbelievably great marketing tool that then you can go to other employers and say, these are our numbers. I mean, I'm not making this up saying we're a great program. You can see it. So that was the real need. As a private care physician, when I was doing this without the business component, I didn't see as much value. As Mahou's developing his team, now I'm starting to see more value from a retail standpoint about where I can integrate this. And again, as we advance further with AI tools, to be able to streamline my communication, to be able to communicate with patients outside of the office or direct links, almost like saying the Netflix subscription. I got to keep in contact with my patients when they're not active with me to show that I'm still active, I'm still here, whether it's a video, whether it's a, hey, hope you're doing well, hey, we haven't seen you for 3 months, give us a call. Those type of things become important. So I'm starting to see this thing really evolve more than just the analytics, but it's more of a touch base to a patient outside of your normal hours.
Yeah, there's a lot of power to the data, and I completely agree with you. I personally, working on Hit Connect, being here, I think employer-sponsored DPC is a primary way to grow direct primary care, to get more clinicians out of fee-for-service and give it to more people. It's just, in an ideal world, maybe everyone would be purchasing DPC out of their own wallets, but the reality is 150 million people have employer-sponsored care, and employers are looking for better solutions.
Right.
But it does change that dynamic that you have two customers now. You have the employer customer, and they unfortunately maybe have been trained to think like, if I'm not seeing a claim, nothing, I don't know if anything's happening. And even with patient testimonies, even with, some basic data, they still need to know if they're going to put $1,000 a year into an employee benefit, that they're getting something. So, Mehul, can you tell us more? You mentioned multiple systems. A lot of DPCs use a lot of different systems. Billing management, EMR, messaging, as Dr. Richter said. Kind of, there are even more new technologies, it seems like, every week coming in for DPCs. What systems do you integrate with today, and kind of what's your strategy there? And to just like go back to basics, when we say integrate, like, what does that actually mean? What information are you getting from those systems, and what do you do with it?
Absolutely. So we pretty much integrate with all or most of the systems that the DPCs use. Beyond that, we also get spreadsheets in a very manual way from TPAs on the claim side, where we actually show the value of patients, the cohort that has gone to a DPC versus a non-DPC, and we clearly see the numbers, which are 30 to 50% savings, because the DPCs are able to spend more time, so on and so forth. But coming back, think of it like the integrations, meaning the pipelines or the hooks that we have with the already infrastructure used by the DPCs, and we are able to ingest most of the data that we require from these systems to tell a story that would fly with the employers. like cost savings, right? The DPC versus non-DPC cohort, the time spent with the patient. We are also working on individual patients, the health outcomes, and we'll show the dashboard as well in a few minutes. So essentially, we are also making sure that the value to the retail patients is also there. So in layman terms, we get data like patient notes, uh, all the information. Some folks follow soap. Some folks just have just running text, and we try to kind of grab everything that we can, uh, which will be used for the analytics. Does that answer your question, Beth?
Yeah, so you take the various components from EMRs, billing software, messaging software, and you bring it all together. And then this might be a good time to show your presentation and kind of see what it looks like. But then tell us what happens next after you put everything together.
Yeah, so when we put everything together, we have built a persona ready system. What that means is the DPCs have the ability to kind of communicate the reports, like download it and send it via an email, or they can use our communication within the health compiler system, that they can just email the report out, or they can invite the employer groups, and they have the real-time access to the data that they need to see. So engagement and utilization is the anchor. As you see, the total active patients, we're looking at the number of encounters in a given period of time, the type of encounter, right? Everything from the care episodes breakdown. We have a formula where we say, okay, this is the patient touch ratio across the total active patients, and
And
this.
if I could just hop in here, since this is something that we're using with Hit Connect, I'll point out that you have Acme Health ACO at the top there. There's a different view of this. If a DPC is working with different employers, they get this view for each different employer, and they can see it in aggregate. Correct?
Absolutely. So there's a drop down, and at the aggregate level, the DPCs see everything for all the employers, but for each employer, they would only have access to their own data. That's very well secured and segregated out.
Yeah. And Dr. Richter, is this a view that you're using with the employers that you
Yes.
support?
Yes, absolutely. Yep. And like I said, you can split that thing out. As I can look at it from the standpoint of providers, all businesses associated, split it out so I can look at data points for each business, each provider under Genova Health, and look at it collectively as well.
Yeah. And what are the areas that have been most interesting for you to see and the employers that you support to see?
It's interesting to me to see how many people are accessing us virtually. The office visit is really becoming rather antiquated, which I'm really glad to see. But it's clearly 60% of our contacts are outside the office, and without the office visit. So that was an interesting aspect. We really, most of our problems are taken care of during normal office hours, so it's not that nightly call, or people worry about how many text calls am I going to get at. No, we're seeing that pretty well. That's been interesting to me to be able to see that breakdown as well, and that's been pretty consistent over there. The other point of this, and I think we'll talk about this, is the engagement. Sometimes you lose track that a patient hasn't engaged with us for like 6 months, and that's alarming to me. And so for me, that gap is, I don't want to see that gap. So that makes me more responsive to say, I got to do something more to engage these patients. And it's creating an active push on you. And I think as providers, you get lost in the flow of the day. You think, who's ever there in front of you is your patient, your patient, your patient. And then out of the blue, somebody will, when was the last time I saw you? A year and a half ago. Oh my gosh, how did we miss a year and a half? So that those engagement gaps become important for me as well.
Yeah.
Yeah, absolutely, and that's what we are seeing as well. The more DPCs that we work with, of all sizes, the engagement becomes pretty important. Now we're talking about care gaps. We call it utilization gaps, to be very honest, internally, and which is largely what we heard is from the DPCs. One of the problem is they're collecting the membership fee every month, but not necessarily everyone is being touched. So using this dashboard, they're able to know that, hey, these are the patients that we haven't touched in the last 30 days. Or we have a custom field that you can where it says 90 days, you can make it 27 days or 37 days, or 6 months. And then we have started to add communication layer on it, which is what we heard is, first we went out with the email as a medium, but then number of DPCs mentioned that text works the best, so we changed that to text. And now we are going to layer it with an AI outbound call ability, so that the AI agents are able to call or text automatically. They learn and then they contact that, hey, these patient needs to be able to we should be contacting these patients at certain intervals that the DPCs would want to that the DPCs are comfortable with.
Yeah, I think that's a really interesting point, because this data is so powerful for both employers. Obviously, they want to know, but they're getting an aggregate. They're not actually seeing, the patient level details, because that's the kind of administrative layer that they get access to appropriately. But DPCs can actually see the data underneath and take action on it if they're using this kind of both in terms of like a CRM as well as employer utilization, correct?
Yes.
Absolutely.
Yeah. Mehul, I definitely want you to go through kind of your other slides, but if we could, we've touched on kind of patient privacy and data security. I think DPCs, more than most clinicians, are really, really concerned about the security of their patient information. They feel very responsible for it, and they don't want, there's a lot of cautionary tales about who you share your data with. So what are the measures that Health Compiler has in place to make sure that whether you're moving between different employers or Health Compilers kind of going in and seeing EMR data, which is very sensitive, that it's going to stay in the right places, in the right hands?
Absolutely. So first thing first, we take security very seriously, and um, all of us come from the healthcare IT as a space. So we have been working with the HIPAA rules and others. So we are both HIPAA and SOC 2 compliant. First thing first. Second is we secure this within the US in a secured cloud that's HIPAA compliant again. And of course, we sign a business associate agreement out of the door as we work with the DPCs. Um, it has been built in a way that, in layman terms, it's multi-tenant, and we the data is not shared between DPCs A and B. Also, the employers are not seeing each other's data. So it has been built in a way that it's not only secured, but it has been structured that the data will never get mixed up.
And sometimes I hear, when you said AI before, I hear people having concerns about patient privacy and who accesses data when AI is concerned. How do you approach that?
Yeah, so we have been very cautious about where do we use AI, and that's why we've been laying low and doing a lot of internal experiments. So we have only launched a couple AI agents, but that's more for the new patients. That is our separate solution called Health Compiler Growth, which helps the DPC practices to make sure that the retail patients are able to kind of join them effectively, and there is no friction. But we have been very kind of cautious about making the AI responsible and not just unleashing the AI on the data. So we still use very secure SMS for the existing patients, but we have not unleashed the AI on it just yet.
Yeah, absolutely. Thanks for that. Do you want to go back to the slides? Haley, do you mind pulling those up so we can see a little bit more about what the Health Compiler dashboard looks like?
Yeah, so this is probably one of the most important slides where the employers definitely want to see the total cost savings. We have a formula that we have kind of come up with, and Dr. Richter has, of course, contributed a lot, with his feedback and everything. So this definitely shows, what is the total value and the savings against the investment that the employers are making. And this always helps the DPCs. They look good in front of the employers, and they're able to tell a great story. We are also working internally to kind of come up with like a long form report, which is almost like a storyline that the DPCs could share it during the QBRs. That would have all the matrix dashboard plus the story, like a long form text, you know, as well. So yeah, so we're very excited about this. This slide particularly is very important. Um, these are the same particular window. This is the bottom piece of it. We divide each uh, you know uh, component of, as Dr. Richter mentioned, about a lot of it is virtual, the encounters. So we show that, hey, somebody was able to get to the doctor after hours and save money and on an urgent care visit, so on and so forth. So this is just a breakdown.
Yep. Dr. Richter, how have you been using the cost savings view with your clients?
Well, the cost savings with the employers, really the patients don't see this, are really not interested in it, really. But with our population view, they really do. Well, they're experiencing it financially. They're seeing it. I mean, one story to note: we've worked with an employer for the past 2.5 years that we've been with them. They saved over $2.5 million in their healthcare costs, and then they've just funneled that money back into the savings for the healthcare cost for the employees that don't pay any extra in their premiums and get more services. If there's nothing more that employee feels that immediately, the employer is happy, but then we can show it graphically. What we've been able to do is where those cost savings are coming from. But and Mahu points out, this is pretty much what we see, is that you got phone, video, virtual for 40,000 saved, in person is 13. We're seeing much more saved because we're doing this stuff virtually as well. And I know I emphasize that a lot, when I do my talks on this, but honestly, if you think about this for the patient perspective, it's not just going to the doctor's office. It's the mom that has to arrange for daycare for the kids. It's taking off time from work. It's being able to rearrange your day. It's the time to be able to get there in bad weather or good. It's gas costs. And if I can do this and carry on with my day and have a text message come to me at the end of the day, that is gold. That is just worth so much. So that's where I see that's where DPC is getting this extra tag. Not only do you have the office visit that is so valuable for so many different things, but you can take care of all types of people. Some people love the text message, some people love the office visits, and so this graphically shows you where you are. And to me, I would be interested in, as we collect this data, how similar other DPC practices are across the board. My guess would be we're pretty much the same, that we've fallen into the same group of people. So that data is going to be important. And then how you arrange. If you feel that, my gosh, the majority of people are using text messaging communication, I better have a good text communication system that doesn't fail me.
Yeah, absolutely. Were you able to do anything like this before working with Health Compiler? Were you doing it manually? No, you just was a gap. Yeah.
If I did it, it was by hand.
Yeah.
I mean, I literally would go chart by chart, patient by patient. 1, 2, 3. They had 3 visits. 1, 2. Oh, I haven't seen them. I mean, by hand, compiling this in a spreadsheet. I mean, it was, it would take me a whole weekend
Yeah,
to
that's
get the stuff
brutal.
done. Yeah.
So, in terms of, this data populating and working, do you have to do anything differently, or do you have to ask the practices that you work with in your network to do anything differently in terms of how they're charting, how they're coding, how they're, tracking messages or anything like that? Like, is there behavior change necessary on the part of the clinician to be able to feed this system?
Yes, there was. And the reason was when we're talking about who we were saying, okay, how do we identify collectively what type of visit did we have with this person? I mean, how do we track it? How do you track it rather than going through the actual interaction? How do you track it? So there's some basics. One, we can't look at a chart that's open, so it's got to be closed. So, but that's good medical practice, is to close your practice after you've seen, or close the visit after you've seen the patient. Number two, we came up with diagnostic codes. And when people are codes from DPC, it's the bad word. But these codes are not billing codes; they're tracking codes, and we've only come up with a handful of them. It's going to be an out-of-office visit, it's going to be an office visit, or it's going to be some procedure that you did complimentary, cryotherapy, EKG, something that you provide for that patient. It's no cost to them that you can track. So I found that rather than the thousands of procedure codes and codes that are out there, we just came out with probably about 10 of them. And so the group that of our practitioners, I'm saying, I want to stay consistent with this. This is the code I want you to use when you see somebody in your office. This is the code I want you to use when they're outside the office. And then we tie that onto an emergency code. So, for instance, if somebody contacts me out of office and says I need a refill for my prescription, that's fine. We'll take care of it the next day. That'll fall into a refill category. If somebody calls up and says, can I get a review of my blood work? We'll take care of it the next day, and that will be almost a visit. But if somebody says, hey, by the way, I'm really feeling bad, I think I have a urinary tract infection, can't wait till tomorrow, it's after hours, we code that with an extra code as an emergency code, because we want to signify that that patient not only had a request for information, but we provided treatment outside of normal hours. And outside of normal hours would have dictated an urgent care or an ER visit. So that takes even a bigger savings for that employer. So we wanted to be able to characterize that. So we have a special code that goes on. So it was really learning a handful of codes to use on those patients before you sign the chart out. It was not cumbersome at all. It was, initially, I gotta tell you, when we were talking about it, I'm going like, man, the last thing I want to go back to is coding. That is the last thing I want to see. But we got it down to where it's really very quick, very easy. It's no interference at all. But that is some changes that we had to make.
And that's relevant because you work with multiple different practices. I would imagine that if it's a single DPC or DPCs within the same practice, they can either use kind of their, have their own personal standards or just use what they're using, and that's flexible from practice to practice.
Well, and also add to this, Beth, one of the things that we toyed around with Genova Health was, can we mandate, which I don't like that word, but can we mandate or require each of our practices to use the same EMR? I said, of course not. I'm not their only business. I'm one component of their business. They have their private businesses. So it was really important that Mahou had the tools to say, we can go across different platforms to still get the same information. And I said, okay, that works out great, because now I don't have to worry about one healthcare record. And if we've provided that healthcare record, I can't provide a provider saying, what patient says, oh, this is Genova Health patient? Oh, I got to go into this EMR for that patient. Then I got to go back to my EMR for the other private patients.
Yeah.
That's not going to be practical. And that's going to be cost prohibitive too, because if Genova Health is carrying the cost for the software, that doesn't work either. So the coding worked out really, really well, because that's a number that's going to be ubiquitous through all type of medical management systems. And Mahou has the tools to be able to interact with those things. So that's the way we were able to work through that.
Yeah, that's really cool. Mahou, would you add anything just in terms of how, any of your DPC clients who are non-networks are maybe using this differently?
Yeah, absolutely. I mean, we're working with some of the larger groups here, and they have several affiliates. Our style is, we kind of alter to their style of, we don't necessarily push them to change how they are coding or how they're making patient notes. So we alter our style to their styles, and pull the data and then massage it so that we can use it for the analytics. But we are also seeing that more and more folks now are using us uh, beyond just looking at the matrix, just what you see, but some of the some of the DPCs are care coordinating, paying out of their pocket for specialty care referrals. They're even writing the plans, and we are seeing more and more of our involvement in the entire self-funded, uh, as a whole, as a benefit, where we are able to pull the data and then show everything from TPAs to
For the claims data.
RX, yeah, claim. And we have done that with Dr. Richter and uh, you know Ben, who's an advisor, benefit advisor. So we have shown clearly the cost savings when working with DPC versus the non-DPC.
Yeah, I always joke sometimes the savings like are too good. Usually they seem almost unbelievable. I always
Right.
wish they looked a little worse because they typically look too good to be true because of the impact of DPC. Um, Dr. Richter, what was, what has your experience been with kind of working with the health compiler team? It sounds like you're a development partner. You continually, it sounds like, have more ideas for them, but in terms of, sharing your experience with other DPCs who may be wondering.
As far as how what I got from Health Compiler, or
Yeah, just working with the team.
yeah, well, again, as Mahu's been, their team has been really great, and what he said is, and I really like this, and it's absolutely true, is that they're not trying to remake your practices and say you need to do this. They look at what you're doing, and then try to come up with a way to analyze your data so that it doesn't interfere with your flow. The other thing I say is there's always new ideas that are coming up with, and it's not like, well, yeah, we've got an AI component here, so you have to use it. It's like, if you want to explore that, we can explore it. There's things that, if this benefits you, then let's go ahead and do this. If you're happy with your messaging system, keep your messaging system. We're not using to replace it. So, but we also have the option that we can take in different things. So one of the things I really appreciated about that very much so is that it really is a partner in my healthcare. It's not somebody who mandates what I do. It's somebody who not say, well, you got to do it this way if you want to work with us. If somebody says, look, I know what you're looking for. You tell us what you're looking for. Not every practice is looking for the same things. Many are going to be very similar. And, Beth and you notice you deal with different practices. You get the same stories over and over again. As I talk to DPC doctors, it's the same stories. It's the same histories, but there are some nuances that are different from the analytic standpoint. And I need a company that's going to be able to work within my intricacies that I want. So that was very big for me. Plus, I want the data to be useful and I want it to be accurate. And initially, we want to make sure that data is consistent. And so that's one of the things that I was working with Mahu and his team to say, how can I consistently make this? And as you brought up, Beth, how can I do this with multiple providers? We've got to be on the same page. So in this aspect, we got to be consistent with the way we see patients. And the other thing, too, to add to this was that we got great cooperation from our Rosetta team, and for the self-funded plans that they worked with, able to get the claims data, which became very valuable. And then that incorporates, because that aspect we have nothing to do with, but what kind of impact are we doing with patients who are truly claims? Are they less claims? Are there more? What's going on? Well, we can see that data, the impact that we've had for those patients, keeping them out of hospital systems and keeping them out of expensive care. Sometimes you don't see that directly. But that's interesting to me that now I can see that as well because we can utilize the claims data.
Yeah, I think I agree. With Hink Connect, we're working with Health Compiler in a very similar manner as you are, working across practices that have a lot of different EMRs, a lot of different ways that they're working. We're not using the claims data analysis right now, but I can see that coming in useful in the future, especially as it can be really hard to get a third party to do the analysis that's really interesting that that you want. So kind of same, I would have the same take and endorsement of working with the health compiler team. They really understand direct primary care. Mehul, what else would you add? What haven't we covered that you want to make sure people know about Health Compiler?
Yeah, absolutely. So we started off as a, in the data analytics and working with several different tools that DPCs are using. But right now, what we also understand is there's several providers who are now making their way into DPCs, and they're looking to grow the DPCs. So we are helping uh, the DPCs that are just getting started, or somebody who wants to kind of grow their DPCs with getting more access to retail patients and staying in front of them, and then making sure that they become a member. So we have some solutions that are AI first solutions, like uh, CRM, but we're not making a CRM in a traditional uh, system of records, but system of action that would take action on behalf of the clinician and on behalf of the front desk, and help them with reaching out to the patients in an automated way. Any incoming calls to the DPCs can be answered by our AI agents, and then a record is present in the CRM.
Nice. So it's kind of full scale from helping practices grow up front with retail and serve those members and not lose them, to helping DPCs who are working with either small or large employers prove the value and retain those members as well.
You bet. Yeah.
Yep.
Let me add also that whose team has come up with a good uh, questionnaire after we see patients that we can kick out there. Hey, did you like your visit? Give me a smiley face. Give me 5 stars. That type of thing is going to be. And because one of the things that I really found interesting, and you mentioned this early on from the employers, they really do want employee satisfaction. That is a big deal. And it's not just that finance, they want employee satisfaction. I mean, a happy employee is a good employee for them, and they don't want hassle and they don't want complaints. And so those abstract values that now I can actually put a number to it becomes very important. Not just say, hey, I think everybody loves us. I said, no, the data shows they love us, and because we have that. So that's an important aspect. I know from that abstract versus concrete and objective numbers, this really gives us more of an objective for an objective type of comment.
Yeah, absolutely. So I know we haven't gotten many comments in. I'll, take that as us having covered all of the relevant points, but I will just pause and say, if any of you who are listening out there have questions that you want answered on this live stream, please send them in now. We can see them on the chat. And if you don't want to ask the question publicly on the chat, I'll ask Mehul, how can people get in touch with you if they want to learn more about Health Compiler?
Yeah, you can use, there are various communication ways. You can visit the hin.com ecosystem page that we have. You can, text with our chatbot on the website, but you can also email us info@healthcompiler.com, or just email me, mehul@healthcompiler.com. I'm deeply involved, and I am, I'm happy to pick up the phone and talk whenever there's a need. Beth, you know that I do still receive calls from the practices, and I still answer calls, and I still make calls.
Yeah, and you will be at the Health Rosetta Hind Summit event coming up in Denver as well.
Yeah, we are very excited to come back. We were there last year, and it was so amazing to learn so much about DPCs and the impact. And of course, find new partners. We'll have our booth again at the Hint Summit Health Rosetta, which will be probably bigger than
Okay, wonderful.
last year.
Well, we're really excited about it. It looks like we haven't gotten any questions in, so we can leave it at that. But Dr. Richter, thank you so much for your
You're
time
welcome.
and expertise. It's always a pleasure to talk to you. And Mehul, congratulations on setting up Health Compiler. I think we're all going to benefit from it. I think DPC is going to benefit from it. And so I'm excited for you to start working with more more DPCs in the ecosystem who are either trying to grow their practice from the beginning or are working with employers and want to keep them happy and satisfied.
Absolutely. Thank you. And thanks for the opportunity, Beth and the Hint team. Thanks, Dr. Richter.
You're welcome.
Okay.
Thank you.
All right. Have a good one, everybody.
Have a good
Thank
one.
you.
You guys.
Bye.
Bye-bye.